All right, everyone, let's get started. Today, we are tackling a really crucial topic in high-risk obstetrics, and that's selective fetal growth restriction. This is something you're absolutely going to need to have a handle on for your rotations, so we're going to break it all down.
So first things first, why is this such a big deal? Well, get this, the risk of stillbirth in twin pregnancies is roughly double what you see in singletons. So right from the get-go, the stakes are incredibly high. Okay, here's our game plan for today. We'll start with what I call the twin conundrum. Then we'll explore how one placenta can lead to two very different fates. We'll get super clear on defining growth restriction itself, and then we'll spend a good chunk of our time on the star of the show, the Graticos classification. Finally, we'll put it all together, connecting the diagnosis to the decision.
So let's jump right into section 1, the twin conundrum. Twin births themselves are pretty rare. We're talking only about 2 to 4% of all births. But, and this is the key, they account for a way bigger piece of the pie when it comes to perinatal morbidity and mortality. And this really gets to the heart of the problem. A major report from MBRAC UK actually pointed to inadequate growth surveillance as a key area of substandard care. So I want you to remember, getting this right isn't just about passing an exam, it's about fixing a real-world gap and improving patient outcomes.
That leads us perfectly into our second section, one placenta, two fates. Now, if there's one word I want you to remember today, it's chorionesty. It is without a doubt the single most important factor that determines the risks and the problems we see in twin pregnancies, especially when we're talking about growth. And that brings us to the core issue. Monochorionic twins, we'll call them MC twins, are twins who share a single placenta. Now, you can imagine, this shared circulation creates a whole host of unique challenges, and the biggest one is that they often don't share that placenta equally.
So let's make this crystal clear. On one hand, you have dichorionic twins. They've got separate placentas. So when one has growth restriction, it's usually for the same reasons a singleton would, something called uteroplacental insufficiency. But, on the other hand, with monochorionic twins, the problem is completely different. Selective fetal growth restriction, or SFGR, happens because one twin is getting shortchanged on their piece of that shared placenta.
All right, moving on to section 3, defining growth restriction. You can't manage a problem if everyone is defining it differently, and for a long time, that was the case here. So there was a huge need to create a standardized, consensus-based way to make the diagnosis.
So that's the big question, right? How do we actually diagnose selective fetal growth restriction? What are the specific, agreed-upon rules we should all be following in the clinic?
Well, here's your answer, and it comes from an international Delphi consensus, so this is what you need to know. It's actually pretty straightforward. If the estimated fetal weight, or EFW, of one twin is less than the third centile, boom, that's it, diagnosis made. But that's not the only way. You can also make the diagnosis if you have at least 2 of these other criteria: an EFW below the 10th centile, a small abdominal circumference, a big weight difference, 25% or more, or really high pulsatility index in the umbilical artery. And once you've made that diagnosis, that leads us right to the main event for today, the Graticos classification. This is the tool you're going to use to figure out how severe the SFGR is in a monochorionic pregnancy. And it all comes down to what you see on the umbilical artery Doppler. Just remember this, the key is in the blood flow. Everything we're about to look at is a direct window into how that smaller twin is doing.
Okay, now focus in on this image, because this is exactly what you'll be looking at on the ultrasound. Over on the left, we have type I. See how the entire waveform is above the baseline? That's positive end diastolic flow, a good sign. In the middle is type 2, and you can see it's worse. The flow at the end of the cycle is either absent, flat on the baseline, or even reversed. That's a huge red flag for placental problems. And then on the right, we have type 3. This one is really tricky because it's unpredictable. The flow is intermittent. Sometimes it's there, sometimes it's absent or reversed. It's a sign of some very unstable business going on.
And this table really sums it all up. Let's just walk through it. Type I, with that good, positive flow, they usually have a stable course, a pretty favorable outcome. Type 2, with that persistently bad flow, that signals a high risk of the baby getting sick, and it often means we have to deliver early. And type 3, the intermittent one, it's completely unpredictable and carries a terrifyingly high risk of sudden fetal demise. Knowing this table is absolutely essential for managing these cases. Okay, so let's put it all together in this final section. Diagnosis to decision. How does knowing all this stuff actually change what we do for our patients? It really boils down to a very clear three-step process. Step 1, you diagnose SFGR using those consensus criteria we talked about. Step 2, you classify the severity using the Grottakos system from the Doppler. And step 3, based on that type, you tailor your whole plan, how often you're going to check on the babies and how you're going to manage the pregnancy.
And look, this isn't just my take on it. This is pulled from major clinical guidelines. The quote says it all. The Grottakos classification serves as a useful tool to inform surveillance strategies and guide clinical decision-making. It really has become the standard of care.
So I want to leave you with this question to think about. We've just gone through a very precise system for diagnosing and staging a serious condition. The real question for our generation of medicine is this. Can we use powerful tools like the Grottakos classification to consistently turn these incredibly high-risk situations into high-success stories?